Welcome to Pulse&Pressors, where critical care gets crystal clear. Dobutamine is a synthetic catecholamine inotrope used for low-output states. Its beta-1-driven contractility boost, combined with mild vasodilation, gives it an inodilator profile ideal when contractility is impaired, but MAP is preserved. Dobutamine is a synthetic sympathomimetic with predominant beta-1 activity and mild beta-2 and alpha-1 effects. As a racemic mixture, each stereoisomer contributes differently. It is metabolized by COMT and hepatic conjugation into inactive metabolites. A short 2-minute half-life allows precise titration. Dobutamine increases contractility through beta-1 stimulation and reduces afterload via beta-2 mediated vasodilation, which slightly exceeds alpha-1 tone. The result is higher stroke volume, lower SVR, and improved cardiac output with minimal chronoatrophy at therapeutic doses, a classic inodilator effect. Indications include cardiogenic shock with adequate MAP, typically greater than or equal to 65 millimeters of mercury, and objective low-output criteria. Cardiac index less than or equal to 2.2 liters per minute per square meter, with wedge pressure greater than 15 to 18 millimeters of mercury. It is also used in acute decompensated heart failure, post-cardiac surgery low-output syndrome, as a bridge to LVAD or transplant, for stress echocardiography, and as an adjunct in septic shock with persistent low cardiac output. Dobutamine increases cardiac output and stroke volume, lowers LV filling pressures, and reduces afterload. This improves perfusion and relieves congestion with less tachycardia than dopamine or epinephrine when MAP is adequate. Start at 2.5 to 5 micrograms per kilogram per minute, titrating upward in 2.5 micrograms per kilogram per minute, increments every 10 to 15 minutes. Most benefit occurs at 5 to 10 micrograms per kilogram per minute. Doses above 20 micrograms per kilogram per minute add risk with little extra effect. Tachyphylaxis occurs after 48 to 72 hours due to beta-1 receptor downregulation. Dobutamine increases cardiac output and stroke volume while mildly lowering SVR. MAP may fall, remain stable, or increase depending on preload and vasodilatory tone. PCWP decreases, improving pulmonary congestion. At modest doses, myocardial efficiency improves despite rising oxygen consumption. Adverse effects include tachycardia, hypotension from vasodilation, ventricular and atrial arrhythmias, and ischemia in CAD. Tachyphylaxis appears after 48 to 72 hours. Rare complications include hypersensitivity and eosinophilic myocarditis. Dobutamine reliably raises cardiac output and reduces SVR, with variable MAP effects and moderate heart rate increases. Wedge pressure drops, improving congestion. When cardiac output improves, global oxygen delivery increases accordingly. Compared with Milrinone, Dobutamine is beta receptor dependent with rapid on-off kinetics. Milrinone's PDE3 inhibition causes less tachycardia, but more prolonged vasodilation, and is preferred in patients on beta blockers. The Do-Remi trial showed no outcome difference, making selection phenotype dependent. Compared with dopamine, dobutamine provides steadier inotropy with far fewer arrhythmias. Dobutamine's variable receptor activity and increased arrhythmia burden, highlighted in SOAP2, led to its abandonment in cardiogenic shock. Dobutamine offers superior hemodynamic stability and lower mortality risk. In cardiogenic shock with MAP greater than or equal to 65 millimeters of mercury and cardiac index less than or equal to 2.2 liters per minute per square meter, dobutamine improves forward flow and perfusion. If MAP is low, pair it with norepinephrine, the vasopressor of choice over dopamine. Avoid dobutamine alone in severe hypotension. It serves as a bridge to recovery or mechanical support and should be weaned as cardiac index and contractility improve. In acute decompensated heart failure, dobutamine enhances forward flow, reduces pulmonary edema, and lowers filling pressures when diuretics and vasodilators are insufficient. Hypotension remains the main limitation. Its use is restricted to ICU settings due to tachyphylaxis and arrhythmia risk. Dobutamine improves cardiac output and oxygen delivery in ventilated patients and can aid weaning when low output is the barrier. Tachycardia at higher doses can worsen dysynchrony. Its mild pulmonary vasodilation helps in pulmonary hypertension and aligns well with lung protective strategies. On VA, ECMO, Impella, or intra-aortic balloon pump, dobutamine enhances LV contractility, reduces distension, and promotes aortic valve opening. Combine with norepinephrine to maintain MAP. Milrinone is preferred when tachycardia is problematic. Continuous arrhythmia monitoring is essential. Use has declined due to tachyphylaxis, arrhythmia risk, hypotension in vasodilated states, and earlier adoption of Impella or ECMO. Milrinone is advantageous in beta-blocked patients. Even so, dobutamine remains effective as a short-term bridge when MAP is preserved. For stress echo, dobutamine is escalated in stages, 10 to 40 micrograms per kilogram per minute, to raise myocardial oxygen demand and reveal ischemia via new or worsening wall motion abnormalities. This is diagnostic, not therapeutic. Tachyphylaxis appears after 48 to 72 hours as beta-1 receptors downregulate, reducing the inotropic response. Higher doses increase risk without added benefit. Rotation to milrinone or escalation to mechanical support is preferred if prolonged inotropy is needed. Prepare at 250 to 1,000 milligrams per 250 milliliters, 1 to 4 milligrams per milliliter. Use an infusion pump. A central line is preferred. Short-term peripheral use is acceptable with caution. Avoid alkaline solutions such as sodium bicarbonate. Wean gradually to avoid rebound hypoperfusion. Monitoring includes continuous telemetry, arterial pressure via A-line, and cardiac output assessment using PA catheter, PICO, or POCUS. Track wedge pressure if available, along with lactate, urine output, perfusion markers, and serial echocardiography to assess cardiac index and contractile response. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.